All right, let's talk about small burns. Small burns are very important to you as an emergency physician because these are things that if you don't work at a burn center, you're going to need to know how to treat because a lot of them can be followed up on an outpatient basis. But when you face a small burn, first of all, you're going to have to know how to recognize the total body surface area to say that it's a small burn, and you're also going to need to recognize the depth. So these are key things. So the things that we've already learned, depth and total body surface area, are extremely important in determining which burns you can handle. We're going to talk about that once again, pain control. We're going to talk about topical antisepsis, what to do with blisters, should you unroof them or not. We're going to talk a little bit about the basic dressings that we use in the emergency department and tetanus prophylaxis. So, again, the depth determines the severity. So, if you don't know if this is a full thickness burn and you don't recognize this as a full thickness burn, that's a problem because almost any full thickness burn warrants referral to a burn center. You're also going to need to be expert at calculating the total body surface area, whether it's a pediatric patient or an adult. Because again, if there is a total body surface area greater than 5% in peds or 10% in an adult, you're going to refer that. So you got to get this right. Next, pain control. I think it's wise to go ahead and use a pain score, the FACES score for children, or a 1 through 10, or a visual analog scale is extremely helpful in determining the severity of the patient's pain. You just can't tell it by looking at their heart rate, their blood pressure, or their face most of the time. Treat liberally, treat aggressively, get in there, make them feel better. Before you manipulate the wound in any way, you need to pre-treat with narcotics before any kind of trimming, debridement, irrigation, etc., because there is a baseline sort of pain that is present with a burn. But if you touch or manipulate the burn at all, or air hits the burn at all, it's going to exacerbate the pain. So go ahead and pre-treat for that and send them home with narcotics. Speaking of sending home with narcotics, don't give codeine to kids. Codeine has to be converted in the body to morphine, and 5 to 10% of patients have a genetic mutation or allele that does not allow them to convert codeine to its active form, and so they get zero pain relief. But on the other side of the spectrum, there are rare ultra-metabolizers who metabolize codeine to morphine far more rapidly than everybody else, and these will actually become toxic, especially if it's a child. 15% of Northern African and Middle Eastern patients are ultra-metabolizers, meaning they can become toxic if you give them codeine. There is a fantastic perspective piece that actually hasn't even come out yet that's still in press in New England Journal of Medicine. You need to read it. Now let's talk topical antisepsis. What I recommend doing is simply irrigating the wound. Treat it as if it was a laceration. Irrigate it with normal saline, or if you like, you can make a 0.1% concentration of chlorhexidine. And that's simple. Just add 10 cc's into a liter bottle until it barely turns pink and just irrigate with that. I do recommend rinsing though. The two topical antibiotics that you need to know are bacitracin and Silvadene. Bacitracin is fantastic. It has a decent spectrum of antimicrobial activity, but the good thing about it is it's soothing. The other good thing is that it will not cause skin discoloration. Bacitracin should always be used on the face, and as a matter of fact, it really should be the go-to topical antibiotic that you use for burns. When would you use Silvadene? Well, I'll tell you first of all when you would not use Silvadene. You never use Silvadene cream on the face. Why? Because it can cause a grayish discoloration of the skin. Remember back in the organic chemistry days, or, well, I guess that would be not organic chemistry, but you see, I'm chemically challenged. Remember back in the chemistry days when you get silver nitrate on your clothes or your skin, and then you wouldn't know it until you walked out of the lab into the UV light, and suddenly it's like developing a picture. The silver nitrate shows up as grayish spots on your skin or on your clothes. It'll do the same thing on the face. Because the active ingredient in Silvadene cream is the silver ion. So don't use it on the face. When would you use it? Well, Silvadene cream would be very useful for a deeper burn. So my thinking is, if you have a deep partial thickness or a full thickness burn that is a relatively small total body surface area, and you're going to send it on to the burn center on an outpatient basis, this would be the perfect patient to apply Silvadene because it penetrates the burn a little more deeply. It also has a broader antimicrobial spectrum. And if you have a burn that's heavily contaminated, let's say it happens out in the barnyard or whatnot, heavy contamination would also be an indication for the broader antimicrobial spectrum that you'd get with Silvadene. What about sulfamylon? Sulfamylon or mafenide is fine. It's mainly used in the burn unit. I mention it because it could be a board question for you. If you apply sulfamylon, it has excellent penetration of the eschar. It's used for deeper burns. It has a broad antimicrobial spectrum. But here's the kind of board type question you might be asked. It can be associated with metabolic acidosis if used for a long period of time. And collagenase is used for superficial partial thickness burns. Our burn people use it a good bit. It kind of breaks down some of the collagen and allows the granulation bed to become very rich and healthy and supports healing. Now, blisters. Blisters are very controversial. A lot of people say unroofed blisters that are greater than an inch or 2.5 centimeters. Just go ahead and take that roof off. Now, others will say, well, you should do this only if it is over a joint and could affect movement. The only evidence that's out there is an article in British Medical Journal, and it's hardly an article. It's basically a single page, almost like a letter to the editor. It was a controlled trial of 202 patients in 1987, and the only evidence that's out there suggests that leaving the blister intact both improves pain control and has decreased bacterial colonization. So what am I going to take away? Well, for relatively small blisters, I'm going to leave them alone. For huge, large, flaccid blisters, or especially blisters that are already ruptured, I'm just going to go ahead and debride that necrotic tissue. That's what I take away. Now, dressings. Once you apply the topical antimicrobial, you need to put a dressing on. Adaptic is the go-to, really. It's just a non-stick gauze. Plain old gauze is going to have the tendency to stick. Adaptic is not going to stick as easily. Xeroform, as you know, is what we wrap around a chest tube, etc. It's just a petroleum, sort of petrolatum impregnated gauze, and that works great. If you have a heavily contaminated wound, Acticoat is more expensive. It's absorbent. It has silver ion impregnated into the dressing, and so that's going to be highly effective as an antimicrobial, both treatment and dressing, and it's going to have a nice broad spectrum, and it doesn't cause the skin discoloration that a silver nitrate would. What about tetanus prophylaxis? We can never forget about this, although it's easy to do when you're in the throes of caring for a burn wound. If they haven't had a tetanus vaccination in over 5 years, give them a Tdap, or if they're a kid, give them a DTaP. Remember, though, there are patients you may take care of who are either undervaccinated or completely unvaccinated. We have a large Amish population nearby our medical center, and these are largely unvaccinated people. These are folks that if they haven't had 3 or more doses of their tetanus vaccine, they need tetanus immune globulin as well as their first tetanus booster. So don't forget about both tetanus prophylaxis and tetanus vaccination. Finally, sometimes burns are very difficult to assess as far as their depth in the early period. There's this intense vasoconstriction peripherally, and it'll make the burn look a little more pale and possibly a little deeper than you might expect. So it's important to reassess the depth of the burn in a day or two. And that is usually done if you're worried about a burn like this in a burn clinic or a burn referral center. Some primary physicians are excellent with this. A lot of superficial, partial thickness burns, small scalds, etc., can be treated by the primary care physician, but you need to be pretty confident that it's a superficial partial thickness and not deeper than that, because a superficial partial thickness is treated largely by benign neglect, just simply preventing infection, maintaining mobility, and 14 days later, it's going to be better no matter what you do. Any full thickness burn needs referral onto a burn clinic. And remember, if it's on the face, if it has any high risk features, you're probably going to send it to a burn referral center right away because it's going to meet those transfer criteria. But when in doubt, refer them on to the burn clinic. So that's your primer on small burns or minor burns. These are burns that are really less than 5% total body surface area in kids, less than 10% in adults, and burns that are not on sensitive areas like hands, feet, joints, GU, face, etc. So, hope that helps you out. We just didn't have time to cover that in the main part of the lecture, and so this is going to be something that you will definitely take into your practice if you go into the community and you're not working at a tertiary care burn referral center. All right, thanks a lot.